have a brief look at this video for next 15 to 20 seconds. So suppose you are posted in a pediatric emergency. This patient comes to you with the complaint of lethargy for last 4 days, decreased acceptance of feed for last 2 days, pain abdomen for last 2 days, and fast breathing for last 1 day. On further examination, you found out that the patient had tachypnea, tachycardia, feeble peripheral pulses. BP was around 60 to 34. Patient had typically fruity odor and bilateral air entry was equal, no added sound, but the patient had deep, rapid breathing. CVS and per abdomen examination was with the normal limit, and on CNS examination the patient was drowsy. GCS was 11/15 and the DTRs were normal, plantars were downward. You did an RBS came out to be 359. The provisional diagnosis of diabetic ketoacidosis was kept. So now you have to make a confirmatory diagnosis of diabetic ketoacidosis, and also so you have to manage the patient according to the protocol. So what about the management part? This video will cover the major aspects of the management of diabetic ketoacidosis in children. So let's get started. So before going in the management of diabetic ketoacidosis, we have to learn something about pathophysiology. I haven't given a detailed view of the pathophysiology. If you already know the pathophysiology, you can skip to management part. So the hormone in the body which is responsible for utilization of glucose from the blood, that hormone is insulin. All other regulatory hormones like glucocorticoids, glucagon, cortisol, growth hormone, thyroxine and adrenaline, or I must say epinephrine, they all cause hyperglycemia. So we can easily say that the insulin is the grandmaster of storage of glucose. During the day, after the meals, the insulin levels generally rises. Now this rise is due to the postprandial hyperglycemia which is occurring in the body. Insulin gets released. This surge of glucose is deposited into the muscles, into the liver in the form of glycogen. So insulin causes a steady state level of glucose throughout the day. So what happens in type 1 diabetes? In type 1 diabetes, what happens is there is decreased insulin production from pancreas. So in type 1 diabetes, there is progressive low insulin catabolic state. Glucose utilization by muscle and fat decreases and the postprandial hyperglycemia appears. In fasting state, the liver produces excessive glucose via gluconeogenesis and glycogenolysis, and fasting hyperglycemia appears. So in type 1 diabetes, there is consistent lower level of insulin which leads to hyperglycemia. What does this excessive glucose does to the body? So what is the harm? So this excessive glucose causes an osmotic diuresis in kidneys. In kidneys, when this excessive glucose reaches the kidney after a threshold of 180 milligram per deciliter of serum glucose, it started coming in the urine. Along with it comes water, sodium, potassium and phosphorus. So in short, this excessive glucose causes diuresis, osmotic diuresis. So there is loss of calories in the form of glucose and electrolytes in the form of sodium, potassium and phosphorus. This all leads to stress. So this stress causes hypersecretion of stress hormones. They are epinephrine, cortisol, growth hormone, glucagon. And we have already done that these stress hormones leads to more hyperglycemia. These stress hormones cause increase in glucose via 4 pathways. They are mainly inhibition of release of insulin from pancreas, antagonizes insulin action on the cells, decreases glucose utilization and glucose clearance, and promotes glycogenolysis, gluconeogenesis, lipolysis and ketogenesis. This ketogenesis leads to accumulation of ketone bodies in the body, which ultimately leads to ketoacidosis and ketonuria. Why does the ketoacidosis occurs? This is because the body is in a state of starvation during type 1 diabetes. The cells cannot utilize the glucose for the energy, so body shifts its energy source towards other byproducts like ketone bodies. So ketone bodies are formed in the liver. What are the products? What are the source for formation of ketone bodies? They are fatty acids. So these fatty acids are formed from the fat cells via lipolysis. These comes to the liver where they are converted to ketone bodies. Ketone bodies comes inside the blood and leads to ketoacidosis. Also filtered from the kidney leads to ketonuria. So what are the clinical presentations of a child with diabetic ketoacidosis? First of all, learn the clinical presentation of diabetes as a whole. A patient with the diabetes will have polydipsia, polyuria, polyphagia. There would be loss of weight, apathy. The patient would generally be lethargic, would not show any interest in day-to-day activities, and there would be pain abdomen. You have already seen the video which showed a deep and rapid respiration, that was Kussmaul respiration. The video link is given in the description, you can go through that. Now the daily doses of water and glucose which is lost in urine is approximately 50% of the average daily calorie intake. They are 5 liters and 250 grams approximately. So the patient is in a state of dehydration and starvation. Now the patient usually land up in diabetic ketoacidosis during an episode of stress. This stress can be incurrent illness, trauma, and this occurs when the counter-regulatory hormones cannot be antagonized by the action of insulin. So let's start with our main topic, management of diabetic ketoacidosis. So coming to the management. So first and the foremost thing we have to look for in a child which comes for DK is to stabilize the child. After a quick examination, stabilization of the child should be done. Look for airways, breathing, circulation and GCS. If the patient lands up in respiratory failure or a GCS of 8 or less than 8, then immediately intubate the child and start the patient on mechanical ventilation. So a confirmatory diagnosis of DKA is mainly done with 3 parameters, also called as triad of DKA. The 3 parameters are as under. First, there is hyperglycemia, meaning greater than 200 mg per deciliter. Second parameter is ketosis, leading to ketonuria. The third parameter is acidosis, meaning a pH of less than 7.35. So these 3 parameters are essential for the diagnosis of DKA. So now we come to categorization of DKA. The DKA is categorized into mild, moderate and severe based on 3 parameters. They are venous carbon dioxide, pH and clinical. So it is to note that the venous carbon dioxide we are talking about is the amount of bicarbonate, that is the major form of carbon dioxide in the blood in the form of bicarbonate. The normal value of bicarbonate in a normal individual is 20 to 28. In mild DKA it is 16 to 20. In moderate it is 10 to 15. In severe it is less than 10. The pH in normal individual is 7.35 to 7.45. In mild 0.25 to 0.35. In moderate 0.25 to 0.15. And in severe 0.15. In the clinical parameter, in mild DKA, the patient is oriented, alert, but fatigued. In moderate DKA, there is gusmal respiration. The patient is oriented, but sleepy. It is to note that the patient is arousable in moderate DKA. In severe DKA, there is respiratory failure or depressed sensorium to coma. It is to be noted that severe hypernatremia, that is corrected sodium of greater than 150 milliequivalents per liter, would also be classified as severe diabetic ketoacidosis. So there is decreased insulin level in the body, which ultimately leads to increased glucose. This increased glucose then pass on to the kidney, where when the threshold is increased above 180 mg per deciliter, it comes out in urine in the form of glucosuria. This ultimately causes osmotic diuresis. This osmotic diuresis causes loss of water, leading to dehydration, which ultimately leads to activation of RAS system, that is renin-angiotensin-aldosterone system. This causes loss of potassium from the renal tubules. This activation of RAS also causes decrease in GFR. In the fat cells, there is lipolysis. This lipolysis causes release of fatty acids, which ultimately reaches liver to generate ketone bodies. These ketone bodies ultimately reaches kidney and comes out from urine in the form of ketonuria. Ketone bodies also consumes the buffer system of the body and ultimately causes metabolic acidosis. So the goal of management of diabetic ketoacidosis is centered around increasing the insulin levels, which would ultimately decrease the glucose concentration of the body, which would ultimately decrease glucosuria, which would decrease osmotic diuresis. Second aim is to increase the GFR and decrease the loss of water. We also have to decrease the lipolysis, which would ultimately decrease ketogenesis, which would ultimately improve metabolic acidosis. With the decrease in ketogenesis, there would also be decrease in ketonuria. So coming to the two main components of diabetic ketoacidosis, that are hyperglycemia and dehydration. So to correct hyperglycemia, we have to give insulin. For correction of dehydration, we have to give IV fluids. So the role of insulin would be movement of glucose into the cells, decrease hepatic glucose production, and to halt the production of fatty acids by the fats. Whereas the role of rehydration would be correction of the shock and improve renal perfusion. Coming to the two main components, insulin and rehydration. Insulin causes decrease in glucose levels, which ultimately helps in rehydration. This is done by decrease in osmotic diuresis. Rehydration ultimately causes decrease in glucose levels by increase in GFR, therefore leading to excretion of glucose in urine. Insulin also causes hypokalemia by shifting of potassium inside the cells. Rehydration causes hypokalemia with the increase in GFR, which ultimately leads to loss of potassium from the kidney. This is due to the high aldosterone levels during diabetic ketoacidosis. Decrease in glucose can also lead to cerebral edema. This is due to decrease in oncotic pressure, which leads to shifting of water inside brain. Which ultimately causes cerebral edema. Insulin also causes decrease in ketoacidosis. Insulin also inhibits the production of ketone bodies, ultimately correcting ketoacidosis. And not to forget, diabetic ketoacidosis is a dehydrational state, and with the rapid correction of sodium, it can lead to cerebral edema. So keeping this flowchart in mind, we would go through all the aspects of management of DKA one by one. So starting with the insulin, we have three main questions in mind. Number one, at what dose the insulin have to be started? Number two, how can a steady state of glucose concentration be maintained with insulin infusion? And when do we titrate the dose of insulin? So coming to the first question, insulin is started at the rate of 0.1 units per kg per hour. So why only 0.1 units per kg per hour? This is because in a normal individual, when we do glucose tolerance test, the insulin which is released is approximately equal to 0.1 units per kg. Coming to the next question. How can a steady state of glucose concentration be maintained with insulin infusion? This is very necessary because with the insulin we have to do blood glucose monitoring. So with the blood glucose monitoring there can be two situations. One is the glucose falls below 300 mg per deciliter and then it falls below 200 mg per deciliter. So if the glucose falls below 300 mg per deciliter, start dextrose D5% infusion. And if it falls below 200 mg per deciliter, start dextrose D10% infusion. So you would be asking why the hell we would give more dextrose to the body. So this is because persistent decrease in serum glucose of greater than 100 mg per deciliter per hour may increase the risk of cerebral edema. Come to the third question. So when do we titrate the dose of insulin? With the management aspect of DKA, we do not titrate the dose of insulin unless until the glucose levels is less than 100 mg per deciliter in spite of giving D10% dextrose. The ultimate aim of giving insulin is not to decrease the glucose but also to inhibit ketogenesis, to improve ketoacidosis. So the insulin infusion can be titrated if there is persistent hypoglycemia less than 100 mg per deciliter in spite of D10% solution. So coming to the rehydration, we have three main questions. What are the timings of rehydration therapy? How do we calculate the fluids in rehydration therapy? And what types of fluids are used in rehydration therapy? So coming to the timings. The timings of rehydration therapy is divided in first 1 to 2 hours and then next 24 to 48 hours until DKA resolution. In first hour, we would focus mainly on correction of shock, and in second hour, we would correct the deficit and give the maintenance. Now coming to the next question, that is calculation of fluids in rehydration therapy. So for correction of shock, we have to give IV boluses at the rate of 10 to 20 ml per kg every 20 minutes. These boluses can be increased up to 60 ml per kg in 1 hour. The correction of deficit and the maintenance. The deficit is calculated as 85 ml per kg and the maintenance is calculated as 100 ml per kg for the first 10 kg, 50 ml per kg for the second 10 kg and 25 ml per kg for all the remaining kgs. So what are the types of fluids used in rehydration therapy? For the first part, for correction of shock, we have to use 0.9% of NaCl or ringer lactate. For correction of deficit and the maintenance, we can give 0.45% NaCl along with D5% and D10% according to the sugar level of the individual. So the calculation of IV rate is done with this formula, which includes the deficit, the maintenance minus the bolus divided by 23. So coming to hypokalemia, we have two major questions. They are, how do we prevent hypokalemia while on insulin therapy, and what to do if we do encounter hypokalemia? So to prevent hypokalemia while on insulin therapy, we give 20 milliequivalents per liter of potassium phosphate plus 20 milliequivalents per liter of potassium acetate. These are added along with insulin infusion and IV fluids. It is to note that per liter which is used in this equation is the total fluid calculated for 24 hours. What to do if we do encounter hypokalemia? If potassium comes less than 3 milliequivalents per liter, give 0.5 to 1 milliequivalent per kg as oral potassium solution, or if the patient is lethargic, cannot take orally, then we can increase IV potassium to 80 milliequivalents per liter. So coming to ketoacidosis, we have 4 major questions. When does the ketoacidosis get corrected? Does ketonuria depicts actual state of ketoacidosis in the body? What if the acidosis does not get corrected? And can't we give bicarbonate for the correction of acidosis? So coming to our first question, when does the ketoacidosis gets corrected? Ketogenesis continues until fatty acid substrates already in the liver are depleted. Bicarbonate buffers and metabolism of ketone bodies steadily repair the acidosis once ketoacidosis production is controlled. So does ketonuria depict actual state of ketoacidosis in the body? No, it doesn't. During decay, most excess ketones are beta-hydroxybutyrate. When with the resolution of acidosis, beta-hydroxybutyrate gets converted to acetoacetate, which is then excreted in the urine and detected by dipstick test. So to normalization of this whole process, this whole process takes about 3 to 4 days. Therefore, persistent ketonuria may not accurately reflect the degree of clinical improvement. What if the acidosis doesn't get corrected? If the acidosis doesn't get corrected, we have to rule out these 4 points, that is inadequate insulin, inadequate fluid therapy, infections, and really lactic acidosis. Coming to our fourth question, can we give bicarbonate for correction of acidosis? Actually, no. The bicarbonate increases the risk of hypokalemia and cerebral edema. Therefore, only in situations with severe acidosis unresponsive to standard decay management, the bicarbonate can be given. So coming to hypernatremia, we have 3 main questions. Is there a relationship between hyperglycemia and sodium concentration in blood? How do we calculate true sodium value for a given glucose level? What is the relevance of this true sodium in the decay? So coming to our first question. So is there a relationship between hyperglycemia and sodium concentration? Yes. The sodium should increase by approximately 1.6 millimoles per liter for each 100 mg per deciliter decline in glucose. So how do we calculate the true sodium value for a given glucose level? This is done by a formula, that is 1.6 into glucose in milligram per deciliter minus 100 divided by 100. What is the relevance of this true sodium in decay? The corrected sodium is usually normal or slightly elevated. In case it is greater than 150 millimoles per liter, severe hypernatremic dehydration may be present, and it may require slower fluid replacement to prevent cerebral edema. So coming to cerebral edema, when do we suspect a child that child is having cerebral edema, and how to manage cerebral edema? So when do we suspect a child is having cerebral edema? The patient would usually complain of a change in consciousness, depressed respiration, worsening headache, bradycardia, apnea, pupillary changes and papilledema, posturing and seizures. So if the patient presents with any of these complaints, the patient can be having cerebral edema. So how to manage a case with cerebral edema? So immediate interventions should include elevation of head of the bed, restriction of IV fluids, administration of mannitol, that is 1 gram per kg, IV infusion over 20 minutes. Some important points to note are that pancreatitis is occasionally seen with DKA. Serum amylase and lipase may be elevated, and if the serum lipase is not elevated, the amylase is likely non-specific or salivary in origin. So when to start oral feeds? The oral feeds are started as soon as the DKA has resolved. So when do we call DKA is said to be resolved? So DKA is said to be resolved when total carbon dioxide, that is bicarbonate, is greater than 50 milliequivalents per liter, pH is greater than 7.3, sodium is stable between 135 and 145 milliequivalents per liter, anion gap is closed, and there is no emesis, that is the patient is accepting feeds normally. Then the patient is shifted to subcutaneous insulin. This shifting to subcutaneous insulin is done by a long-acting insulin. The insulin drip is discontinued approximately 30 minutes later. Frequent, every 2 to 3 hours, short-acting insulin boluses may be given until ketosis resolves. The shifting to subcutaneous insulin is done with short-acting insulin in basal bolus regimen. The basal bolus regimen is not to be covered in this video but would be covered in subsequent videos. So to conclude, DKA is an emergent complication in type 1 diabetes. The DKA needs prompt and careful treatment. Insulin is the mainstay in treatment of DKA. Monitoring electrolytes during treatment is very essential. Persistent acidosis may indicate another underlying pathology. And it is to note that in pediatric patients, do RBS as a part of vital examination at the time of admission of a child to the emergency. I know the video went a little longer, but I have tried to cover each and every aspect of the management of DKA. If you learned something new, do like the video and subscribe for more updates. I have also shared the PowerPoint link down in the description. Go check it out. There is a huge number of topics to be covered. All will be covered from Nelson. So stay tuned. If you have any suggestions, leave comment below. I would be happy to hear from you and would try to make the suggested changes in upcoming videos. Thanks for watching.